Good afternoon, everyone. This is Brian Robson, the Medical Director at Healthcare Improvement Scotland, and welcome to this, the second in our exciting lineup of QI Connect WebEx sessions in 2017. The 32nd since the series began. You'll recall that QI Connect provides an opportunity for colleagues across health and social care and beyond to learn from international leaders in the fields of improvement, innovation and integration. And we've designed these sessions to be short, accessible and recorded to allow access at a time that suits you. So let's make a start today, and I'd like to introduce Jennifer, who's going to take you through how we're going to be using WebEx to get the most out of today's session. Good afternoon, Jennifer.
Thanks, Brian, and good afternoon, and welcome everyone to today's WebEx session. I'm just going to take you through a couple of quick housekeeping slides to get us started. If you could please use the chat function that you see on the right-hand side of your screen to communicate, and I'll talk you through how to do this in just a moment. And if you do have any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function, or call the number *0 on your cell phone keypad. So these sessions are designed to be a fun, interactive learning experience, and we do encourage you to use the chat function to share any questions, comments or ideas throughout the talk, and there will be an opportunity for Q&A at the end of the session. So if you can just click on the speech bubble for chat, just circled here in red, type your message and then press send. And I should also flag that we'll be sharing hyperlinks within the chat function to any resources mentioned by the speaker today. So we did promise it was going to be fun and interactive, so we'd now like to find out where you're all going to be joining us from. So if you can just click on the pen icon, the top left-hand side of your screen that you circled there in red, and then click on the arrow icon that you'll see on the left-hand side of your screen, and then click on the map where you're dialing in from today. So welcome Keith. Lots of people from the UK. Oh. Great, thanks everyone, and I'm now just going to hand back over to Brian, who's going to tell you a little bit more about the QI Connect series and some of the organisations who are joining us today.
Wonderful, Jennifer. Thanks very much, and great to see John up there in Stornoway, Chelsea over in Canada, I think, and welcome to our colleagues from all over the UK. I think today, Jennifer, how many countries are joining us live?
There's 8 countries who are registered for today's session. Yep.
Great, wonderful. And you can see the reach of QI Connect. We're now reaching more than 525 organisations, which is an amazing growth. We're delighted to have so many organisations join us. But before I describe those organisations, let's go to the competition. As Jennifer says, we're trying to keep this live and interactive. So again, we're looking for you to use your arrows and identify the new country that's joined us today for the first time. And the new country that's joined us today I'm going to name, and the first arrow gets a wonderful prize. So the country today is the Czech Republic. The Czech Republic. Oh, well done, Barry. Barry Melia. Well done, Barry. The Czech Republic is the new country that's joined us. Well done, Alex. Bit slow, but no cigars. Well done for that. And Barry, delighted to say that today's prize, as well as a QI Connect mug, you also get a copy of a wonderful book, Frugal Innovation, How to Do More with Less. A little bit more about that in a moment. But well done, Barry. And that is absolutely fantastic. Well done. Now, the organisations that we have, we now have, when we started the series, we had 1 slide with your wonderful logos. We're now 15 slides of your tremendous logos. Great to see so many people from all over the world joining QI Connect. And we're always delighted to say that the whole of NHS Scotland, all of the NHS branded organisations in Scotland also join QI Connect. So it's great to have so many of our friends and QI connectors across the world and here at home in Scotland. And we're always delighted to call out the universities. We've now got 51 universities that join us, again, from all over the world to share and learn together. I'm delighted to say that 3 new universities that have joined us, the University of Bath, the University of Oxford, the Said Business School, and the Al-Qura University from Saudi Arabia. So you're most welcome to join us on QI Connect. And a special mention to the new organisations. We have 11 new organisations, from the Gretna Surgery in Dumfries and Galloway, a GP surgery maybe 100 miles from where we're sitting just now in Glasgow. The King's Fund are joining us formally, and you can see the other connectors, the new QI connectors. Great to have the Greater Manchester Academic Health Science Network with us, the Family Nurse Partnership and others. Welcome aboard. And we've highlighted this previously, but the recordings of QI Connect are proving to be very, very popular, and delighted to say that many of our colleagues that can't join us live use the recordings both in their personal and their team and indeed their university programs. Delighted to see the reuse of the resources. And you can find all of the resources going all the way back to the very first talk on the Healthcare Improvement Scotland website. And we're delighted to highlight again that in 2017 we have a brand new partnership with the Health Foundation. The Health Foundation is an independent charity committed to bringing about better health and healthcare for the people in the United Kingdom, and is well known for its Q initiative, a UK-wide initiative to develop and connect innovators and improvers in health and social care. That's a new partnership for QI Connect for 2017, and we're very excited by that. We're also excited to be continuing our partnership with the International Society for Quality in Healthcare, and the ISQA program, their fellowship program, use the QI resources as part of their accredited resources. I'm delighted to highlight the QI Connect, a small but perfectly formed team. You've heard from Jennifer and myself. We have Carmen, who does all the administration and will provide all of the certification after today's event. We have Michelle, who's working with us here on registration, and of course we have Alex working with us on Twitter analytics. That's a small but perfectly formed team that will be joined today by Jill Patterson, who is a Scottish Clinical Leadership Fellow working with Healthcare Improvement Scotland and the Scottish Government Chief Medical Officer. Jill is a forensic psychiatrist and taking a year to learn about leadership, and Jill will be asking the first question of today's speaker. And just remember, everyone, we love the reach that Twitter can bring, so please tweet as you learn, hashtag HISQIConnect, and of course follow us at HISQIConnect. So without further ado, I'll introduce today's speaker. All over the world, public finances are under unprecedented pressure, and so there's never been a more important time to make the most of our resources. In April last year at the IHI BMJ International Forum in Gothenburg, I heard today's speaker captivate the 3,000 plus audience in the hall with stories of how people with very little created dramatic improvements. And when I mean very little, I mean very little, oftentimes nothing. So it's important for us here in the West to understand that better. And today's speaker has studied both how we can learn from areas of frugal innovation and do the boomerang into Western society, and how Western society can learn amongst itself also. Professor Jaideep Prabhu is the Professor of Marketing at the Judge Business School in the University of Cambridge. He's extensively published and a leading academic and has worked internationally in the field of marketing, business and engineering. And I'd just like to welcome Jaideep to the call. Good afternoon.
Thank you, Brian. Hello, everyone. It's a great pleasure to be with you. Let me say a little bit about myself by way of introduction before I start with my topic of frugal innovation. I grew up in India. I studied engineering as an undergraduate there. I then went to the States and switched to business. I got a PhD in the business school at the University of Southern California. I taught at UCLA and Tilburg University in the Netherlands before moving to the UK. Throughout my career, I've studied innovation. In the first part of my career, I studied innovation in large Western corporations because the understanding was that's where innovation happens. And then in about 2008 or so, I became interested in innovation in emerging economies like India, where I'd grown up. And when I went to India and talked to innovators there, I was struck by how their approach to innovation seemed different from their Western corporate counterparts in at least three ways. First, these innovators were very frugal in their approach. They were very good at taking cost out of the whole innovation process and doing more with the limited resources they had. Second, their approach was very flexible. They were very good at improvisation and lateral thinking. They might start with a plan, but they were good at moving to another plan and yet another plan as the situation demanded. And finally, many of their solutions seemed designed to bring people who were outside the formal economy into the formal economy, and so were inclusive in their approach. Let me give you some examples of what I mean. So here, by way of contrast, it's a bit of a caricature, but it helps make my point, is an innovation that we might expect in an affluent society. This is a high-end fridge that will talk to you and you can talk back to through that tablet PC. And for that pleasure, you pay about $3,000. Now, as I said, it's a bit of a caricature, but you often see this with large companies. They have structured R&D programs, which can be quite expensive. Often they're investing in technology for the sake of pushing the technology frontier. They come up with some new technology, which they then put into their products to differentiate them, and then they charge the customer for that. Now, in a country like India, you may see something like that fridge, but you're equally likely to see something like this fridge. The one on your left is $3,000. The one on your right is about $30. It's a clay fridge. It uses the cooling properties of water that are stored in the reservoir at the top, not only to keep the water there cool, but also to keep fruit and vegetables that are in the compartment below fresh for up to 3 to 5 days in a hot climate. This is very frugal. It just uses clay and water to achieve its objective. I'll tell you a bit about the entrepreneur in a second. You'll see that he had a very flexible mindset, and also his intention was inclusive. He comes from a village in the Indian state of Gujarat, and his idea was to develop a fridge for people like himself, people who would like to have a fridge but often cannot afford one, and even if they could afford one, may not have access to electricity. Now, here's another example. This is an incubator. It's a beautiful machine. It has all the best bells and whistles from a company like GE, and it costs about $20,000. Now, at that price, it's beyond the reach of millions of people who live in developing countries, particularly those in rural areas, where the rural clinics will not be able to afford these devices. Even if someone were to give it to them, they may not have access to electricity, and they may not have technicians who can maintain the devices. In a situation like that, something like this would be very powerful. So the incubator is $20,000. This baby warmer is about $20. Now, obviously, it's not an incubator. It doesn't have, for instance, an oxygen tent, but it is designed to address a large part of the problem that the incubator addresses. One of infant mortality, where if an infant is born 1 or 2 weeks prematurely, they won't be able to maintain their body temperature. In many cases, they may die, and in other cases, they may be severely affected for the rest of their life. This baby warmer will save them and help them. Interestingly, it wasn't developed by a large corporation. It was developed by 4 students who took a course at Stanford called Design for Extreme Affordability, and the objective of the course was to come up with a working prototype that was 1/100th the cost of the existing solution. They could choose any problem. These students chose the problem of infant mortality and incubators, and they came up with this device. When they graduated, they went on to commercialize it, first testing it with mothers and midwives in Nepal and then in rural South India. They got venture capital backing from people at Stanford. They tested it in the medical hospital, and eventually GE entered into a non-exclusive licensing agreement with them to help commercialize it. Now, I've spoken to literally scores of such innovators, not only in India but elsewhere. And in India, when I've asked them how they would describe this kind of frugal, flexible, inclusive approach, they often use this Hindi word jugaad to describe it. So my co-authors and I, when we ended up writing a book on the subject, called the book Jugaad Innovation, where we define this as the art of overcoming harsh constraints by improvising an effective solution using limited resources. It's not a perfect solution, it's a good enough solution that importantly makes use of the resources that are available. And when we were blogging about this book, even before we published it, people from other parts of the world wrote to tell us that they had equivalents in their countries. For instance, the Brazilians said that they had two related concepts that kind of captured this idea. And we saw this in other emerging markets, but also in the developed West, and I'll return to that in the second half of my talk. So what we did in our book was to look at scores of examples and try and extract some principles we thought were guiding these frugal innovators. And here they are. First, these innovators are very good at doing more with less. They take advantage of the resources they do have and use them to substitute for resources they don't. Second, the solutions are often simple, and this helps not only to economize on the inputs, but it also enables easy use and maintenance of the solution. Third, as I mentioned, there's a lot of lateral thinking, a lot of thinking and acting flexibly, and the idea here is if you cannot climb the mountain, find a way around it. Fourth, often these innovators are inspired by adversity. Necessity is very much the mother of invention, and they find opportunities in the most adverse circumstances. Fifth, often their solutions are designed for excluded groups, and it's not just as consumers, but also they involve these excluded groups in the solution itself. And finally, they are very passionate. They follow their hearts. They're deeply committed to the problems they're trying to solve, and this is important because often what they're trying to do is quite hard and requires persistence. Let me introduce you to some of the people we wrote about. This is Mansukh Bhai. He's the person behind the clay fridge I mentioned earlier. He's from a village in the Indian state of Gujarat. He has a high school education and comes from a family of potters. In 2001, his state suffered a very serious earthquake, and a lot of people lost their household possessions, including the clay the clay pots in which they traditionally stored water. These would be sort of earthen pots, which are very traditional. One morning he opened the local newspaper and he saw a picture of someone's clay pot that was broken, and the caption read, "Poor man's fridge broken." And that actually gave him the idea to come up with a poor man's fridge. So he designed the fridge that you see in the picture. He set up a factory in his village where he trained local women to make them, and he went on to sell these on the internet and elsewhere. In many ways, he embodies these 6 principles I mentioned. First, finding opportunity in adversity. The earthquake actually gave him this idea. Doing more with less, using clay and water that's widely available. Keeping the solution simple, as you see. A lot of lateral thinking and improvisation was involved. Including the margins, he was trying to reach people like himself who would like to have a fridge, but he also involved them in the solution, training local women to make these fridges so that they could earn an additional income. And finally, he's deeply passionate, and you can see him on the internet talking about this innovation and others that he has come up with. Now, here's another type of innovator we covered in the book, a different sort of innovator, Dr. Mohan, a diabetes specialist from the Indian city of Chennai. Now, diabetes is a very serious problem in Indian cities, but people in cities can afford to go to private practices like Dr. Mohan. They can pay for it and they get a good service, and Dr. Mohan has a very thriving practice in Chennai. But he's aware that diabetes is also a problem in the countryside, in villages where people don't have access to this expertise. He knows that people in the village, even if they know what diabetes is and think they have it, will not go to the city for treatment. It's too far away and expensive. And equally, his doctors from the city will not go to the village. So he came up with this solution, a mobile clinic that you see there. He worked with the World Diabetes Foundation that gave him the van and the equipment inside the van that you see in the bottom. He worked with the Indian Space Research Organization that gave him the satellite dish on top of the van. The van goes from village to village and stops there. People like the lady you see in the bottom step into the van. They're from the village. You step into the van. She looks through the eyepiece, and that image is broadcast by a satellite to the doctor sitting in the city who can see it on his computer screen, make a diagnosis, which he then communicates to the gentleman in the bottom, who is a local health volunteer. So Dr. Mohan selects people like that, trains them in the city for a few days, and then they return to their communities where they act as a local health volunteer. They know when the van is coming, they bring people to the van, and then they follow up when the van is left. So you see many of these kinds of solutions in India. Another example, perhaps quite well known, is in the context of cataract-related operations. Aravind Eye Hospitals was started by Dr. V in 1976, and there's now a network of such hospitals. They've treated over 35 million patients, having done over 4 million surgeries. And the idea is that those who can pay and can afford to pay, and that subsidizes those who cannot afford to pay. Doctors rotate between free and paid wards, so they ensure that quality is uniform across those who pay and those who don't. There's a great focus on quality control, and you can see that the rate of infection is equal to international standards. They initially had problems with importing the lenses because that was expensive, so they ended up making the lenses themselves to reduce costs even further. Another example in healthcare is that of Dr. Devi Shetty, a cardiac surgeon who was trained in Guy's Hospital in London and then went back to India and was very disappointed that there were very large numbers of Indians who simply couldn't afford cardiac surgery. So he made it his objective to be able to reduce the cost of such surgery. And he set up this very large hospital in Bangalore, a 1,000-bed hospital where they do something like 30 major heart surgeries a day. And his emphasis has been using principles from scientific management, like economies of scale, division of labor, and so forth, to be able to reduce the cost of surgery without compromising quality. And he's been able to reduce the cost to something like $1,500 and aims to reduce it even further to $900. And to prove that this can be done elsewhere, he's expanded the model to other cities, not only in India, but also in the West. Large organizations, particularly multinationals, have been getting into this space in countries like India. GE, for instance, has its largest R&D center outside the US in Bangalore in South India, where they have been designing a whole suite of medical devices specifically for the Indian rural market. For instance, ECG machines, which they realized couldn't be large, which sat in hospitals, because typically doctors would go from the city on a day trip to rural clinics. So if the doctors were going to be able to use ECG machines, they would have to be portable, they would have to fit into a doctor's bag, they would have to run on batteries, and they would have to, of course, be highly affordable. So GE came up with the specification that you see in front of you. And then they also used an approach that they had found their Chinese and Indian local competitors approached to innovation, which was to work backwards from what was available off the shelf. So for instance, they knew that they needed a component which would be a printer. So they looked around and said, well, bus ticket printers, we can use those components. We need keypads, well, telephones have keypads, we can use those components. So they took off-the-shelf components, they applied a quality control standard, and very soon they had a solution that was suited to the local context, but that was also much more affordable. This product was successful in India. They launched a similar product in China, and now they have FDA approval for these devices to be sold in the West. In fact, GE's CEO, Jeff Immelt, has gone on record as saying that he expects healthcare products like this developing countries like India to be exported to the rest of the world. Some of these models have applicability in Europe and the US. Siemens also has a very large R&D center in Bangalore, and they too have been developing affordable medical devices. And here you see, for instance, a device that's used to monitor the status of the fetal heart. It doesn't use expensive ultrasound. It uses very easy to maintain microphone technology. Perhaps the best example of a multinational doing this kind of frugal innovation at scale in developing countries is Nokia. In that pomp, they developed devices like the one you see in front of you, specifically for people who lived in urban slums in cities like Sao Paulo or in Accra in Ghana and in Mumbai in India. They noticed that people were buying what was then quite expensive devices. This is the late 90s. But because it was a prized possession, they would cover them in plastic to protect them from dust and grime. And they would use the light in the phone to see their way in the dark. So they took those insights on board and came up with this robust, affordable phone which had these features, a built-in flashlight and a dust-proof keypad. And that made this phone a phenomenally successful device. In fact, devices like this are now ubiquitous in the developing world. I read the other day that there are now more mobile phones in the world than toothbrushes, which is probably somewhat alarming for dentists, but very useful for people wanting to offer services to people who are outside the formal economy but have access to mobile phones. For instance, in Kenya, Vodafone's subsidiary set up a service in 2007 for people like this lady you see from a village in Kenya to call her son, who might be in the city in Nairobi, not only to speak to him, but also to request him to send money home, which he can do simply by texting on his phone. He can text money to her, which she can receive onto her phone, and she can then cash at the local corner shop. And this kind of mobile payment system has been a huge boon to people who don't have access to bank accounts, but are part of the migrant economy. So much so that Kenya now has something like 25 million people who are on this M-Pesa platform. And now there are many services that can be offered to them. I'm also struck by how startups or NGOs can piggyback on large companies. So here is the example of Simon Berry, who came up with this idea of Cola Life, anti-diarrhea kit, which he developed based on his experience in Africa. He says that he was very frustrated to find that you could get a cold Coke bottle even in a remote village in Africa, but you couldn't get vaccinations or an anti-diarrhea kit. So he said, if you can't beat them, join them. And his brilliant idea was to come up with a kit that would fit between the gaps between Coca-Cola bottles in a Coca-Cola crate. And so they could piggyback along with that Coca-Cola crate when it made itself to remote villages in Africa. A final example I'd give is one from a large Bangladeshi organization that I work quite closely with. This is BRAC. By some accounts, it's the world's largest NGO, employing over 100,000 people and reaching something like 126 million people, not only in Bangladesh, but now in 11 countries in Asia and Africa. And they are in many ways like a parallel government because they offer primary health, primary education, microfinance, and so forth at the village level throughout the country, particularly in Bangladesh. Interestingly, even though they get a lot of aid, they have revenue generation models, and they're able to cover a large part of their costs through their own revenues. And they're constantly learning. They've adopted best practices from business. They try out pilots, and then they very quickly decide how to improve these pilots and scale them across the country. Now, that book which I mentioned, Jugaad Innovation, came out in 2012, and it was very much about emerging markets and what Western companies, organizations going to emerging markets could learn from their counterparts there. But after the book came out in 2012, we realized there was a lot of interest in frugal innovation in the West for the West, partly driven by the financial crisis and pressures on household and government budgets, but also driven by the fact that increasingly small teams of people in the West are increasingly empowered to do more with less. Sometimes even teams of students can do now what only large companies or the government could do 10 or 15 years ago. For instance, take the case of these 4 students from Northwestern University in Chicago who call themselves Design for America. When they graduated from the university, 2 of them had an engineering background, 1 had a business background, 1 had a design background. When they graduated, they said, well, if you want to solve all the problems in the world, you don't necessarily have to go to Africa or Asia. There are plenty in the American backyard, such as, for instance, the problem of hospital-acquired infections, which leads to something like 100,000 deaths in the U.S. alone every year. So they said, what could we do about it? So the first thing they did was to go to a local hospital in Chicago, talk to the doctors and nurses, and observe them. And very quickly they realized that the doctors and nurses had every intention of being hygienic, but there were many moments when they couldn't go to a wall unit to dispense the gel. So they brainstormed, they went back to their studio. There's a small room that had computing equipment and a 3D printer, and they said, what would a kid do? Well, the kid would probably just wipe his hands on his trousers. So what if we took that wall unit and had it clip onto the doctors and nurses' scrubs? So that's what they did, and they came up with a device that you see there, Swipe Sense. They came up with a prototype in their studio. Then they realized they needed to manufacture these, so they outsourced the manufacturing. For distribution, they listed it on Amazon and websites like that. And because they didn't have an advertising budget, they were forced to use social media and they did a TED Talk that went viral. So the whole process of getting an idea, coming up with a prototype, then manufacturing and marketing it, all this could be done by 4 students taking advantage of ubiquitous tools that are available to all of us. Another example of this is closer to home for me. This is a former student of ours here in Cambridge, Evan Upton, who came up with the Raspberry Pi. Evan was responsible for student admissions into computer science here in Cambridge. And he and his colleagues had noticed that over time there were fewer people applying to study computer science. And even those who were applying often hadn't tinkered with the inside of a computer or done any coding. So they said, what if we could come up with a computer that was so cheap you could give one to every school kid, and even if they broke it, it wouldn't be a big deal, and they would be forced to code and tinker. So that's what they did. They came up with that device you see him holding in his hand. And initially they thought, they'd sell a few thousand units. They've now sold several million of them, making this perhaps the most successful computer to have come out of the UK. And it's not just kids who are using it, but they're often their parents, particularly their dads, who are using these devices to make other Frugal devices. For instance, this other student of mine, Prabhu Subramaniam, has taken the Raspberry Pi, given it a cladding, branded it Co-Learner, and loaded it with something called the Khan Academy, which is the entire US school curriculum that's available for free in video form on YouTube. And his idea is that for kids around the world who don't have access to the internet, but do have access, for instance, to TVs, which they could use as a display, if they took this Raspberry Pi, connected it to the TV, then they would be able to access the same learning materials that their more privileged counterparts in the West could have access to. This is an example that spun out of UC Berkeley, a company called CellScope, that's leveraging the huge computing power that we have in our pockets, in smartphones, which are also connected. They've come up with several medical devices that connect to the smartphones through the audio jack and can be used to do various things. So for instance, here you see an otoscope, and a mother can take very high-resolution pictures of the inner ear of her daughter when she has an infection and send those to a consultant sitting remotely. So this standalone, this device, CellScope, this otoscope, is a fraction of the cost of the standalone medical device. And they've come up with other devices like dermoscopes and so on. And this also, of course, encourages people to be more involved in their own health. 3D printers are now increasingly accessible. This one that you see in front of you is about $180, which puts it within the reach of even households in the West. But if you cannot afford a 3D printer, you can go to spaces that might be called tech shops, fab labs or make spaces, where for a monthly fee you get access to a range of tools, including 3D printers and laser cutters. But importantly, you get access to a community of tinkerers, like-minded people who can help you with your solution. An example of something that's come out of the make space in Cambridge, we have one in the center of town, is Simprints. This is 4 students, one of whom was my student, who over a period of 3 years developed the device you see in front of you to help in public health campaigns in developing countries, where often the doctors go from the city to the village and don't know the identity of the person they're in front of. They don't have medical records in paper form that they can access in the village. So the idea was to take the fingerprint of the patient as their identity, convert the visual information into text, which could then be sent via text message by the doctor through their mobile phone to the district hospital, where you could pull up the medical records, text them back, and then the doctor would know, for instance, whether the child needed a vaccination or not. This was 4 students who knew what the problem was, knew what kind of solution they wanted, but had no technical knowledge. Working in the makespace, they met software programmers from ARM, which is Cambridge's largest company, who pro bono helped them to develop this device. And when they were ready, they got funding from the Gates Foundation, from ARM and DFID, and now they're doing very large trials of this product in Nepal and Bangladesh. A lot of this, as I said, happened in the makespace. You'll remember the baby warmer I talked about at the start. So here we have the baby warmer. Just as an example, the students in Stanford went to a tech shop where they were trying to develop this prototype. They didn't know how they would ensure that the temperature was constant, but they met someone in the tech shop who was a former NASA scientist, and he told them about phase change materials, and that's a key component of this solution. This is Jane Chen here, one of the 4 students with Obama, who's a fan, and indeed Obama hosted a maker fair for people like this, makers, in the White House in 2014, and you can see why his focus was to promote local manufacturing in various parts of America. So let me just quickly wrap up a couple of minutes to ask the question of what does all this mean for large organizations? So we wrote a follow-up book in 2015 called Frugal Innovation, where we reflected on this question. And much like the previous book, we looked at lots of examples and tried to extract some principles. And again, we came up with 6. But I won't go into all of them. They're all in the book. I'll just focus on a couple of the last 2 ones, how large organizations can tap into the energy of these makers, these prosumers, in order to innovate faster, better, and cheaper. One example is that of Ford, the auto company in Detroit, which partnered with Tech Shop in Detroit to allow Ford employees to go and tinker with people in the local community. And when they did this, they found that it not only improved the morale of their employees, but also their productivity. They ended up generating more high-value patents as a result of this partnership. Another example is of GE. You see the Chief Marketing Officer of GE, Beth Comstock, there, with this 20-something founder of a company called Quirky. So why has GE gone to Quirky? What does Quirky do? Quirky is a platform where communities essentially crowdsource innovation from people like you and me. So we sign up onto the platform and we suggest ideas for new home appliances, which others vote on. Quirky then selects the most popular ones to take forward, to prototype and then to manufacture and commercialize. So GE went to Quirky and said, can you help us revitalize our air conditioning line? And as it turned out, there was a person on the platform, Garth and Leslie, who had suggested a smart air conditioner that you could control with your smartphone. And now that's being commercialized by Quirky and GE jointly, and Garth gets a part of the revenues. Let me end with a final example of Barclays, the bank in London, trying to use the data that they have on us to develop apps to help us to manage our finances better. They could try and do this in-house, but they're very hierarchical and siloed and have a compliance culture, so it's hard for them to do innovation quickly. So they set up an accelerator where they incubate startups on a 3-month cycle, where the startups are mentored by people from the bank, and they benefit by getting insights from the mentors into how banking works. And equally, the mentors learn a lot from the startups. And at the end of 3 months, these startups pitch to the bank personnel, and Barclays makes a decision on whether to incorporate them or to invest in them. So in conclusion, I would say the challenge for large organizations is how to do more with less, how to be agile, and how to include excluded groups. And 3 possible solutions. One, like Ford, large organizations can give employees time and space to experiment, like Ford did with Tech Shop. Or like with Barclays, they can engage with agile entrepreneurs through accelerators. Or like GE and Siemens, they can create this emerging market mindset by going there and operating in places like India and Africa. The challenge for small organizations is almost the opposite. They are flexible by nature, they don't have a legacy system and have to be frugal, but often they have challenges scaling, and that is where they can partner fruitfully with large organizations. So let me just conclude by saying that based on my research, I strongly believe that the world needs this kind of frugal, flexible, and inclusive innovation. I think small and large organizations from both the developed and developing world can learn from each other. And I think working together, we can improve lives everywhere. Thank you.
Jaideep, that was absolutely tremendous. Wow. Taking us all over the world and giving us lots of examples, and the chat box has been alive, and we'll come to that just in a moment. But let's reintroduce Jill Patterson. Jill is the Scottish Clinical Leadership Fellow, as I mentioned, working here in Healthcare Improvement Scotland, and also with Catherine Calderwood, the Chief Medical Officer for Scotland. So welcome back, Jill. What did you think?
Thanks, Brian. I thought that was excellent, and thanks, Jaideep, for that really interesting talk. What it gets me thinking about is my work at the moment. I'm working on realistic medicine with the Scottish Government and here with Healthcare Improvement Scotland. We started to make links with Creative Scotland and other creative organisations, and really started to think about using innovation in service design principles to improve healthcare. Do you think that there's a role for creative industries in healthcare, and how do you think that they can most effectively work together?
Well, thanks, Jill. That's an excellent question, and I think there is definitely a role. I think design is key to effective innovation. It's key to being able to not only understand what the problem is from the customer's perspective, or from the patient's perspective, or from the organizational client's perspective, but it can also fundamentally help you then design the appropriate solution to that problem. So I think a lot of the examples I gave are not really about technology. Technology is almost incidental to the problem and the solution. But key to all these innovations is really understanding what's the problem from the perspective of the person whose problem we're trying to solve, and then designing perhaps a tangible product which uses technology, but very often an intangible kind of service, and more importantly, sometimes a kind of system that enables that solution to be effective and also viable. So I think design is crucial, and working with people from the creative industry would be a very interesting and I think innovative thing in itself. An example I gave was of Design for America. The fact that they call themselves Design for America is itself very, I think, instructive. But you can see how they applied those kinds of design principles, those user-centric principles, to come up with the solution of SwipeSense. And I think that that partnership that you are developing between people in the creative industries and people in healthcare is a very fruitful one.
Thanks, Jaideep. That's really useful, and certainly it's really positive thinking about the future for realistic medicine and some of the work that we're doing. Thank you.
Thanks, Jill. Now, Jaideep, we've got a whole series of comments here, but there's a few comments around the kind of culture that needs to be in place to make innovation fly. Charles Swainson, who is the e-health clinical lead at the Scottish Government, previously the medical director of NHS Lothian, one of the longest standing medical directors in Scotland, was saying that the innovation is very possible. However, the current climate may be poor, maybe resistant, and it feels sometimes like battering your head against a brick wall. And he says it's really not about money; it's more about the kind of culture. And Gautam Ray, who's a consultant physician in Paisley and an SPSP fellow, also says that a number of the areas that you talked about resonate with the concepts of Clay Christensen and disruptive innovation. But he goes on to say that innovators often have to constantly fight with those who believe that innovations are not so good and not so useful, and it makes it unpredictable whether innovations will be accepted or sustained. So comments there around the culture within which innovation is fostered. What would your thoughts be around that?
So Brian, those are excellent observations and absolutely spot on. I couldn't agree more. I think people are intrinsically creative. They often, especially when they're dealing with people with problems face to face, they recognize these problems and then they're moved to come up with solutions. So I think that, we have that capability in us. The challenge often happens when we are in organizational contexts where there are processes and structures that get in the way of us doing more of that stuff. So this is particularly true in large hierarchical bureaucratic organizations, whether in the public or the private sector, because over a period of time they've introduced structures that are needed to make the large organization work. They've introduced processes to ensure that there is quality control and so forth. So obviously you need those kinds of things, but often those structures and processes get in the way of people coming up with new solutions and then taking them forward and then scaling them. So culture becomes very important, and to some extent related to it, the structure of the organization becomes very important. Now, what kind of culture, therefore? I think this is where large organizations can learn a lot from smaller organizations, where you see startups and entrepreneurial organizations very much being flatter, more agile, where people are empowered at different levels, not only to identify ideas, but also to develop solutions and take them forward. So I think large organizations can potentially try to replicate the conditions that you might see in small organizations, startups, within the context of the large organization. That's one way to go. So you can create sort of a smaller kind of skunk works within the large organization. Sometimes that can be itself very difficult to do. So another option becomes where you create that small organization at arm's length. So it's not within the old organization where the old culture might smother the startup or the skunk works, but you create something at arm's length, which you create a new organization for, a new structure for, and a new kind of culture for, and let them do the innovative piece that you want to focus on, but with a dotted line to the top management. And sometimes a third option is something in between, which is something along the lines of what I mentioned Barclays was doing, where you might have an accelerator or something like that, where you incubate startups, you mentor the startups so that the startups benefit from your experience and capabilities, but equally your people in the parent organization, in the bureaucratic hierarchical organization, are infected by the enthusiasm and the energy of people in the startups. So I think the culture piece is a big one. I've spent a lot of my career actually focused on that question, and both the books I mentioned have at least one chapter towards the end that focuses on this question of how do you create such a culture of frugal, agile innovation, particularly within the context of large, hierarchical, siloed organizations.
Thanks, Jaideep. I could hear everyone nodding when you were describing large hierarchical organizations and the NHS. But some great examples there of how even in those sorts of organizations you can make innovation and frugal innovation work. And in fact, Fiona Mitchell-Hill, a safety leader in NHS Grampian, describes how you've launched an innovation hub in Grampian, and we're giving staff the opportunity to pitch. And they just had their first session, which was great, and launched some simple changes that could be made. So that sounds like skunk works of types up in NHS Grampian, which is super. Jaideep, we've got a question here from Mags Watson, previously of Aberdeen University and a Improvement Science Fellow with the Health Foundation. Mags is now the Professor of Health Services Research in the University of Bath. And Mags is asking, Jaideep has discussed frugal innovation in terms of products. I'd like to know how we could adopt this approach in terms of services, i.e. how might we apply frugal innovation to reducing demand on the health service or increasing capacity in healthcare?
Again, a wonderful question. And actually, sometimes, it's easier to give examples which are products because you can actually show pictures of them and they're very tangible. But really, a lot of the innovation that one sees, frugal innovation that one sees, whether in the emerging world or the developed world, is around services. And of course, sometimes there is a product that is part of that, but really what's innovative is the system whereby a service is being delivered. So when I gave the example, for instance, of the diabetes telemedicine, the mobile clinic, yes, there are some physical, tangible technologies involved, but really what's interesting is the overall service, the overall structure of operating structure to deliver a service of healthcare. Equally, when you look at things like the eye hospital, the innovations there are really around what might be called the service or the business model. The innovation is around how you get cross-subsidization between people who can pay to people who cannot, how you organize the hospital, how you have doctors move around the wards and so forth. Equally with the cardiac surgery example I gave, a lot of the innovations are really to do with what might be considered, process innovations, the process of division of labor, who does what in the surgery, the process of surgery, how you engage paramedics relative to the cardiac surgeons, how you engage the family itself in helping with the recovery process. Also, some of the innovations there are in management information systems, how you get important information on costs and revenues on a daily basis to the doctors, sometimes sending them text messages with a summary, a daily summary of the performance in the hospital. So while some of the examples seem to be centered around products, really, in fact, around those products often is a service. Same can be said of banking and so forth. So I'd say that these ideas really apply not just to physical products, but increasingly to intangible, complex services.
Thanks very much, Jaideep. I think I'm right in saying that the Arvin Eye Hospital leaders have been out at the Golden Jubilee Foundation Trust here in Scotland to give them advice on high volume, high quality cataract operations. And if anyone from the Golden Jubilee is on the line, let's hear about that in the chat box. But there's a question here. This is from Cara Afsal, who is a program development lead in the Greater Manchester Academic Health Science Network. And she asks, he asks, how can you use the academic health networks in the UK to leverage the frugal innovations mentioned? There are obvious savings to be realized.
So again, wonderful question. And I think this was another question I saw in the chat box. There are plenty of brilliant ideas in the world. There are also plenty of innovations which actually enter into, somebody actually implements them, which do not diffuse. And so they say small scale. You see this in farming, you see this in healthcare, you see this in entrepreneurship. You see someone in one village or in one town or in one hospital has a great idea, but people in the neighboring village or the neighboring town or hospital have not benefited from it. So I think this is where networks like yours, like QI Connect, can help in a very important aspect, which is to document and diffuse ideas and innovations, to discuss things that have been tried in one place, to see if they can be applied in another place, whether they need to be adapted or not, and then when they've been adapted, how they've worked. I think this is very important, and I think this is where networks can help. And now it's not difficult. In fact, this whole webinar we are doing is a fantastic example of frugal innovation, a brilliant way you brought together people who are in the same area thinking about the same problems but dispersed geographically. And I think more of that is needed, where people can share ideas, discuss things that are working, why they're working, if they're not working, why they're not working, how they can be improved, and then shared and diffused across networks.
Thank you very much, Jaideep. Now, there's a number of comments in the chat box. Tom Gibb, who's the operations manager at SALAS, which is an NHS-based occupational health service, on the earlier comments around telemedicine and telecare, he said the use of affordable technology to reach remote clients without moving expensive clinicians is very attractive. Kirsty Brightwell, who's an associate medical director at NHS Western Isles, is saying, yes, that's very true. However, we're very quick to find reasons why things won't work, such as information governance, rather than seeing the overall benefit. Caroline Chambers, who's a service improvement coordinator at NHS Orkney, was commenting earlier in the call also. What she was asking there was digital connectivity. It might be a huge challenge. And I just wonder how digital connectivity, how they get around that in India and other developing areas across the world.
Yeah, that's a great question. So I think on the one hand, connectivity can be hugely empowering. It can be the source of many innovations, including particularly, I think, telemedicine, to ensure that people who are in remote areas get the advice of experts who are in cities. I think it also helps people be more engaged in their own health and helps them to be more preventative, which again is a very frugal way, I think, for a system. So the question then becomes, how good is the connectivity? And this is where, again, it's important to go back to the point about user-based design, in response to Jill's question. And if we go back to the example I gave of the 4 students here in Cambridge who came up with Simprints, this device to use fingerprints in developing countries in rural areas, they knew from the start that they couldn't expect a smartphone. They couldn't expect that the doctor would have a smartphone in the village. They couldn't expect that there would be high bandwidth and so forth. So they had to work from the minimum kind of technical capabilities they expected. And they knew that they would have at least a feature phone, and they knew that they would at least have some basic ability to send text messages, which is why they focused on converting the visual information into text so that that could be sent by at least the basic technology that would exist. So I think that's very important. One needs to take into account what is the possible in the circumstances that one is designing a solution for, and one shouldn't immediately rush to adopt the most sophisticated technology that's available. Rather, one should, I think about what is most likely to be ubiquitous in those circumstances and use that. So I think going back to this question, I think there was an implied thing in there, one of those questions you asked, Brian, which was about, this question of, there's a huge amount of risk involved, let's say with data and things like that. And often when we know that we can use telemedicine, we can use distance these devices to help, but we worry about data protection and so on. And it's good to worry about those things because there are unintended consequences. And this is where, again, I'm a big fan of the approach that startups use, which is you try a pilot. You try it in a relatively non-risky situation, in one context, with a few customers or even one customer, and then you study the effects of that. You look at both the unintended consequences and the intended consequences. You look at what's good, what's bad, what are the risks, and then you try to refine your solution in that relatively risk-free situation before expanding it, extending it to more people. And this is exactly what BRAC does very effectively in Bangladesh. When they try out new programs, they try it in a pilot, they work on it for about 6 months, they study it closely, often with the academics, and then they fine-tune it, they try it again in a larger sample, and then if it works, they extend it. And I think this is exactly what medical professionals have been doing for years, for instance, with drug testing. And I think that kind of approach should be applied also to innovations in healthcare.
Jaideep, thank you so much, and thanks for all your insight and answering the great questions. Thanks to everyone who's been chatting away on the QI Connect. I think we'll leave with a comment from Michelle Gillis, who's a consultant in public health medicine, that summarises and says, I think much of this comes down to creating a culture that embraces innovation. It's interesting to see the examples where employees who are given a degree of freedom develop wonderful ideas. Jaideep, I'd like to thank you very much on behalf of the QI Connectors all over the globe. I'd like to remind everyone in the QI Connect, of the QI Connect sessions for 2017, just a little diary alert. Emmanuel Gobelot we're just changing the date of his session, so we'll get back to you this week on Emmanuel's date for the next session. Emmanuel is a wonderfully engaging speaker about how you develop staff and how you develop an organizational culture, actually quite relevant to today's talk as well. So just remind you all to follow us on Twitter and enjoy the rest of the day where you are, and thanks to the team here at QI Connect. Thank you very much.